Hi everyone, welcome back to my YouTube channel. I have already posted part 1 of calendar year 2024 Medicare Physician Fee Schedule Final Rule. Today I'm back with part 2. So today I will be talking about few more takeaways from CMS Final Rule for calendar year 2024 Physician Fee Schedule. Let's get started. Rural health clinics and federally qualified health centers. CMS is finalizing conforming regulatory text changes to implement sections 4113 and 4121 of the Consolidated Appropriations Act of 2023, specifically extending payment for telehealth services furnished in rural health clinics and federally qualified health centers through December 31st of 2024, delaying the in-person requirements under Medicare for mental health visits furnished by rural health clinics and federally qualified health centers, and including marriage and family therapists and mental health counselors as eligible for payment. In addition, CMS is aligning enrollment policies so that addiction, drug, or alcohol counselors who meet all of the requirements of mental health counselors to enroll with Medicare as mental health counselors will also apply for rural health clinics and federally qualified health centers. CMS also notes that Section 4124 of Division FF of the Consolidated Appropriations Act of 2023 established Medicare coverage and payment for intensive outpatient program or IOP services furnished by a rural health clinic or federally qualified health center. CMS's finalized proposals are described in the calendar year 2024 Outpatient Prospective Payment System Rule. CMS is finalizing their proposal to extend the definition of direct supervision to permit virtual presence in rural health clinics and federally qualified health centers through December 31st of 2024. CMS is also finalizing their proposal to change the required level of supervision for behavioral health services furnished incident to a physician or non-physician practitioner services in rural health clinics and federally qualified health centers to allow general supervision rather than direct supervision, consistent with the policies finalized under the physician fee schedule during last year's rulemaking for other settings. CMS is finalizing their proposal to include remote physiologic monitoring and remote therapeutic monitoring in the general care management HCPCS code G0511 when these services are furnished by rural health clinics and federally qualified health centers. In addition, CMS is finalizing their proposal to include community health integration and principal illness navigation services in the general care management HCPCS code G0511 when these services are provided by rural health clinics and federally qualified health centers. Rural health clinics and federally qualified health centers that furnish CHI or community health integration and principal illness navigation or PIN services will be able to bill these services using HCPCS code G0511 either alone or with other payable services on a rural health clinic or federally qualified health center claim for dates of service on or after January 1st of 2024. CMS is also finalizing a change in the methodology to calculate the payment rate for the General Care Management HCPCS code G0511 that takes into account how frequently the various services are utilized. Finally, CMS is clarifying that obtaining beneficiary consent for chronic care management and virtual communication services is required, but the mode of obtaining the consent can vary and direct supervision is not needed. Opioid treatment programs or OTPs. CMS is finalizing its proposal to extend current flexibilities for periodic assessments that are furnished via audio only telecommunications through the end of calendar year 2024. CMS will allow opioid treatment programs to bill Medicare under the Part B OTP benefit for furnishing periodic assessments via audio-only telecommunications when video is not available to the beneficiary, to the extent that use of audio-only communications technology is permitted under the applicable SAMHSA and DEA requirements at the time the service is furnished and all other applicable requirements are met. Supervision policy for physical and occupational therapists in private practice. Since 2005, CMS has required physical therapists and occupational therapists in private practices to provide direct supervision of their therapy assistants. CMS is finalizing a regulatory change to allow for general supervision of therapy assistants by physical therapists in private practices and occupational therapists in private practices for remote therapeutic monitoring or RTM services. This will align with the remote therapeutic monitoring general supervision policy that CMS finalized in their calendar year 2023 rulemaking. Diabetes self-management training or DSMT services furnished by registered dietitians or RDs and nutrition professionals. CMS is finalizing an amendment to the regulatory provision at 410.72D that they established during calendar year 2022 physician fee schedule rulemaking that clarifies that an RD or nutrition professional must personally perform MNT services, but the enrolled registered dietitian or nutrition professional, when acting as the DSMT certified provider, may bill for or on behalf of the entire DSMT entity regardless of which professional personally delivers each aspect of the services. This finalized policy builds on recent policy changes designed to improve access to DSMT services. Telehealth proposals for diabetes self-management training or DSMT services. CMS is finalizing the proposal to allow the entirety of DSMT services to be furnished via telehealth. CMS is also finalizing a policy that will better align billing rules for DSMT furnished in person and via telehealth. These policies are expected to promote access to historically underutilized DSMT services that have been shown to improve care for individuals with diabetes. Expanded diabetes screening. CMS is finalizing their proposal to expand coverage of diabetes screening to include the hemoglobin A1C or HbA1c test. CMS is also finalizing their proposal to simplify and expand diabetes screening frequency limitations and to remove the specific clinical test criteria from the codified definition of diabetes for screening, MNT, and DSMT regulations. Their final rule will remove barriers, reduce provider and patient burden and confusion, and allow for greater person-centered care. Medicare Diabetes Prevention Program or MDPP expanded model. CMS finalized changes to extend the Medicare Diabetes Prevention Program expanded model's public health emergency flexibilities for 4 years, which will allow all MDPP suppliers to continue to offer MDPP services virtually through December 31st of 2027 if suppliers maintain an in-person Centers for Disease Control and Prevention or CDC Diabetes Prevention Recognition Program and utilize the new HCPCS G code for distance learning. CMS also finalized changes to simplify MDPP's current performance-based payment structure by allowing fee-for-service payments for beneficiary attendance. Requirement for electronic prescribing for controlled substances or EPCS for a covered Part D drug under a prescription drug plan or a Medicare Advantage and prescription drug plan. CMS is finalizing the provision as proposed to continue the practice of issuing a prescriber notice of non-compliance as the non-compliance action for subsequent measurement years. CMS may consider a prescriber's non-compliance under the CMS EPCS program in their processes for assessing potential fraud, waste, and abuse, which in some instances could result in a referral to law enforcement or revocation of billing privileges in the event that evidence of fraud, waste, or abuse is present. CMS is also finalizing the provisions as proposed to remove the same entity exception, determine compliance by counting unique prescriptions in the measurement year by prescription number assigned by the pharmacy and include in the Part D claims data. This would exclude refills, which are not separately transmitted from the compliance calculations, and include renewals, which are assigned a new prescription number by the pharmacy. Update the exception for emergencies to allow CMS to identify which emergencies qualify for the exception and establishing that, as a default, prescribers impacted by the recognized emergency exception would be accepted for the entire measurement year. Updates to extraordinary circumstances waivers to further clarify the process for applying for a waiver and the circumstances in which CMS can grant a waiver, and establishing that approved waivers would apply to the entire measurement year. CMS is also affirming that, as discussed in the proposed rule and under the existing regulation at 423.160A5, the CMS EPCS program will continue to align with Part D e-prescribing standards. This is it for today. Thanks for joining me. I appreciate your time and interest. If you found this information useful, please consider subscribing to my channel. Hope to see you next time. Bye now.